Thanks very much, Rick. Thanks for the invitation to come and speak here. I'm a consultant in clinical biochemistry and metabolic medicine. Actually, I used to be full-time until December last year. I'm now part-time, just doing research, just doing Alkaptonuria. I got into this purely by chance in 2003 when a patient approached me. He had Alkaptonuria at the time. He's called Robert Gregory. He died in 2014, but he came to me because there was nothing there at all in the UK for Alkaptonuria at the moment, at that time. And he said, could you please help me set up a society? And that is how I got involved in Alkaptonuria. Some of you may know that this is quite an iconic disease because this was a condition which was recognized to have an inheritance pattern where Mendel's laws were recognized by Bateson, who reminded Archibald Garrett, was working in GOS at the time, that these patients that he was working on, alkaptonuric patients, were showing the same form of inheritance that was described by Mendel. So it's quite a special disease from that point of view. It also led to the creation of the field of inherited metabolic disease at the time. I'm delighted that I'm also a co-founder and medical director of the AKU Society. So this talk is really about focusing on how the AKU Society have played a part in a clinical trial in alkaptonuria. Okay, so I'm going to set the scene by telling you a little bit about the disease, which has implications when you're thinking about a clinical trial. So all the highlights are the ones I'm really going to be focusing on. So it's a highly rare disease, 1 in 250,000 to 1 in a million. That means I think we're going to struggle to find patients if we're going to start doing a clinical trial. So you've got to have a strategy as to how you're going to find the cases. I'm sure many of you will know that there's no national register for rare diseases, but I believe it's coming in 2 or 3 years' time, which is great news. But for want of a disease, you need a way of identifying patients for the disease of interest, and I will come back to that in a minute. It is an autosomal recessive condition where the problem is you can't break down homogeneous acid. So you've got phenylalanine, tyrosine arising from diet. These are amino acids in diet, and they can't be broken down because there's a missing enzyme, homogeneous dioxygenase. So this homogeneous acid then turns the urine black, but it also accumulates inside the body, and you can see the elbow joint of a patient at postmortem, and you can see that the elbow joint is completely blackened. So, and that's because of this process called ochronosis, the ochronotic pigment that these patients develop. It's an autosomal recessive disease, so when we are looking to find cases, we're looking to find brothers and sisters when we found somebody, so that's quite important for us. There are some countries where the disease is highly prevalent, much more prevalent anyway. So it's 1 in 20,000 in Slovakia and Dominican Republic, and we certainly got to work with Slovakia, which I'll tell you about. And of course in Jordan, in some areas, is 1 in 125. Virtually everybody there has got a small pocket, have got 50 cases in a very small area. And that also came in handy when we were doing the clinical trial. It is slowly progressive, and that's an important thing to think about when you're doing a condition. If you're trying a treatment, then you need time to show an effect. So it is a slowly progressive condition. And it's also highly debilitating. It's a multidisciplinary disease, so that some of the tests we have to do to keep track of the disease, you need to do a lot of tests. And again, I'll come back to that. I mean, the major problem with alkaptonuria is it affects a lot of systems, especially the joints and especially the spine. And you can see the gentleman there that I've shown is only 55. It's hard to believe, isn't it? So he's got severe kyphosis, and he's got a lot of disease. The great thing for us, which has led to this effort, is the fact that there's the possibility of a treatment. It is a drug that has already widely been used in a different condition called hereditary tyrosinemia type 1, which many of you may know about. And that same drug works by blocking the enzyme which prevents the conversion of the hydroxyphenyl pyruvate to the homogeneous acid. So by doing that, you don't form homogeneous acid, and therefore the disease improves as a result. So And the Liverpool connection, the person in ICI who was working on this herbicide at the time was Ted Locke, and he's actually in Liverpool. He's the one who made the connection that this substance called leptospermone from the bottlebrush plant, from which nitisinone was derived, was actually a tyrosine pathway blocker. So when we were in 2003, we thought it was fairly simple. We wanted to identify people with AKU, give them nitisinone, and all done. And the reason for that was the NIH in the US was already trialing nitisinone. So, so between 2005 and 2009, they ran a clinical trial in the NIH, the National Institute of Health in the US, their premier institute. And what they did was they identified 40 people with AKU and gave 20 people 2 milligrams of nitisinone, and the other 20, they were not given any treatment. And what you can see there clearly in this figure is in blue are those who didn't get the nitisinone, the urine homogenic acid, and in red are those who got the nitisinone, and you can see how fantastic the drug is in terms of decreasing the homogenic acid, and it's 95% lower in these patients. So you would have thought this is a biochemical cure, really, but yet the regulators insisted on their having a hard endpoint. They want to see a clinical benefit. And this is a challenge for a lot of rare diseases like ours, where you have to show that there's a change in the disease, not just a biomarker. So unfortunately, they didn't know enough about the disease. They went with the lateral rotation of the hip. They were saying we would show a difference, a better lateral rotation in those on nitisinone than those who didn't, and they couldn't find it. So therefore, the study was termed inconclusive. So we then got going because we said, okay, this is an opportunity for us to still continue to develop nitisinone, and we realized that the 20 was too small for such a disease, and they didn't know enough about natural history, and said we need new tools to follow the disease. And the way we did that was we did case finding, and I'll tell you about the identification program that we carried out, and we also did natural history study, and we did from the natural history study, we also developed ways of assessing the condition which we didn't have before. And I must say the AKU Society was a huge driver providing crucial funding for all of this. Okay, we couldn't have done it without the AKU Society. So you're going to this format in the first bit of the presentation, which is really about a simplistic way of showing a clinical trial, which is the design, the setup, conduct, analysis, and report. In highlight, you're going to see those bits where the AKU Society have played a crucial part. In identifying trial patients, as I said, we carried out a survey in the UK, 16,000 GPs. We contacted them, sent them a questionnaire, postal questionnaire, which we're repeating after that by emails and other ways. And within a year, we found 81 patients, starting with 4. Okay. And one of the strategies we used for identifying was AKU Society staff went to conferences. And in the conferences, people from all over the world came to the stall and told them that they had patients. Through that, we were able to develop a map of people not just in the UK, throughout the world, Europe and the world, which again was important for us. As I said, to understand the disease, we got a grant from the National Lottery, interestingly enough, because we were funding these studies at that time, $500,000 to develop a mouse model. And then we also did a human natural history study with a relatively small funding, Chilbrick Trust, of $60,000, which helped us a lot. The AKU Society was the crucial entity which helped us get these funds. I think we have to be very clear on that. When you're thinking about a pre-trial preparation, and we knew we wanted to use nitisinone in this trial, we needed to start thinking about the kind of expertise that you need to run a clinical trial, a bit like the list that you had. And I'll show you the list of people that we managed to put together in terms of consortium of partners for that. In 2011, 2011 is really fantastic. 2011, 2012 for AKU. In 2011, we did two things. One, we applied for funding for a national centre with NHS England highly specialised services. We also applied for funding for a European grant at the time. We weren't sure whether we'd get any or both or none. So fingers crossed at the time when we applied. And in 2012, we got the funding for both. And that was a mixed blessing, which I'll tell you about. The Framework Programme 7 of the European Commission gave us 6 million euros to trial Nitisinone for Alkaptonuria. And you can see that we did rather well. Again, the AQ Society, Nitisinone, has been crucial in terms of helping us write the application as well, polishing it. So we did quite a lot together. So this is a sort of map of the identification of patients that we found through the question I posted. And you can see typically in a country where consanguinity is not high, it is well dispersed in the UK. The cases are all over. And you can see we found cases all over in Europe as well, 551 patients, which was useful, which we used as we went forward. This is the sort of design of the trial that we were thinking about. So the trial was called SONIA 2. SONIA meaning Suitability of Nitisinone in Alkaptonuria. And this is 2 because we had done 1. And the first one was to determine the dose of the drug because it had never previously been done by the NIH. So we did the dose of the drug and we found that 10 milligrams was the best, which we applied for this condition. Now, you will see there the design of this is there are two arms, Nitisinone arm and no treatment arm rather than a placebo, because you can't use placebo in this condition because the urine is black when it's untreated, and as soon as they get treatment, you can see the urine clearing up within 2 weeks. So you can't fool people into thinking that you're getting the study drug, which is a huge challenge in terms of patient retention and recruitment. And you can see this is a 4-year study, 4 year and a month. So we had a screening issue, and again, screening was complex here because we had to get patients from Europe because the patients that we thought would come from the UK to the site could no longer come because they were eligible to come to the National Centre to get Nitisinone for free. So all those patients were completely lost to this clinical trial. So we had to go to Europe for the Liverpool site to get patients. And that is really challenging. How do you do that? Because these were patients that we were never in contact with. We didn't even know that they had AKU confirmed by anything. So there's quite a logistical challenge in terms of getting all of the data from their local doctors, translations involved, all the data security things you had to put in place, the consent. So it's quite a complex thing. And of course, the AKU site had to do a lot of that. Okay, so it gives you an idea. So after the screening and randomization, when the patient then came, we had to check all this out to make sure it was actually correct. Then followed through for 4 years, either Nitisinone or no treatment. And then after the last visit, they stopped the Nitisinone, and then there was a telephone closeout at the end of that. So these are the numbers. So we had 70 patients in the no treatment arm and 70 patients in the Nitisinone arm. And you can see the 3 sites there, one in Pišťany in Slovakia because they had a lot of patients. We thought they had a lot of patients, but still had trouble recruiting even in the site. And they recruited 65 and 42 in Liverpool and in Paris 33. So this was the sort of numbers that we went in with. We ended up with 41 in Liverpool, 65 in Pišťany and 32. So we did 138 out of a possible 140 that we were looking for. So in terms of visits to the sites, we had 6 visits. That's an important thing to remember because these are patients who are fairly disabled, who have to travel from Europe by plane and be fit enough to come. So there are a lot of challenges in bringing patients 6 times to a trial site as well. A lot of tests. These patients had a lot of tests. And the reason for that is because it's a multidisciplinary disease. We didn't want to make the same mistake that the NIH did. We wanted to make sure we had all bases covered. So we had to do a lot of tests. And Tim Cox in Cambridge told us that these sort of studies need to be information rich, and that's exactly what we did. So we did a lot of tests to collect a lot of information about them. And you can see they're just, it's not complete, by the way, the list that I've shown you there, rheumatology tests, the safety assessments, the scans that these patients had, the questionnaires they had to fill, photographs of the eye and ear, urine test, ear biopsy, metabolomics, so a lot of things that we did that we're doing in these patients, which means they had to spend a lot of time, disabled patients, carrying out these tests. You can't do it in a day, so typically what happened was they came on a Monday and they went home on a Friday, okay? And that's a lot of time for them to take away from work, from wherever they are. So these are all considerations when you're thinking about recruitment and retention of patients in the trial. I don't think there'll be a larger study than this. I think there's going to be a larger study in AKU ever, and hopefully we are doing everything that's going to give us a lot of information about the disease going forward. But if you want the scientific way of presenting or painting what SONIA 2 is the international multi-center randomized, evaluator-blinded, no treatment control, parallel group study to study the efficacy and safety of once daily nitisinone in Alkap after 12 months of treatment, followed by an additional 36 months. We were 100% confident of finding the primary outcome, and 99.7% decrease in homogenic acid. So we think we've already got it because it's 1 year. But we had a conversation with the EMA before we started, because you can't start a clinical trial to license a drug without having a conversation with the regulators, which we did right at the start. And they said, you don't know enough about the disease, just stick with the metabolic endpoint, try and show some trend in benefit, and we will license it. And that is the reason for the 36 months, because we already know that we've got a 99.7% decrease in homogenic acid in these patients. So these are the players. So again, you can see there all the things that the first speaker has mentioned there. So we've got 3 study sites. We've got 4 laboratories. The one in laboratory in Liverpool is doing all the metabolic tests. The Bratislava is genetics. Copenhagen is biomarkers, cartilage and bone. Siena is doing oxidation, inflammation markers, and so on. And we've got one CRO who is an expert in orphan diseases from Amsterdam, again found by the AK Society through their connections. And we've got 2 patient societies, the one based in Cambridge and Paris. There are other societies as well, Jordan and many others are involved, but these are the 2 main ones that are funded by this project. We've got a pharma company which had the license for nitisinone when we started, Swedish Orphan Biovitrum, and they had the license for nitisinone, so they came on board, and that's a hugely welcome thing, because I don't know whether you know the cost of nitisinone. It's about £12,000 per patient per year. So that means that's 2 million in funding would have gone straight for funding nitisinone. So the fact that they came on board and they're providing this trial drug for free is a huge, it's allowed us to get on and do the study. The 2 sponsors, NHS institutions cannot provide indemnity outside the UK, so therefore the university as a sponsor came on board. And of course the funder was the European Commission for that. In terms of the setup, highlighted bits are the ones where the AK Society have played a part, and you can see that there's a lot of setup activities that we had to carry out, and of course they, as the patient society, they looked at the patient information sheet, the consent forms, and in terms of translation to see whether it's appropriate and all the rest of it. We wanted to have a project management team when we started who would look at the whole of the logistics and the patient visits and look at the patient side of it. We also wanted to have a clear works packages looking at patient support, and we also had a crucial involvement from the society in terms of the screening of the pre-visits and the peri-visits when patients came. I've already mentioned that. And in terms of governance, the The optimal trial management was carried out by a mechanism which I will describe shortly. And the AKU Society was also part of the trial steering committee where the meetings took place once a year. So in terms of running the project, this is my first effort at a clinical trial, by the way. The R&DI in my hospital were horrified. You're doing such a complex study. You've never done a clinical trial before where you've led on it, because I've done lots of supportive clinical trials, statin trials and bone trials and the other bit. But to run a clinical trial of this complexity, they were quite surprised. So the way we kept hold of it was to have weekly project board meeting. The whole consortium, 13 partners, met once a week, and we sorted problems out. So if there were any issues, we were able to sort them out at that point. We also ran retention and recruitment teleconferences. In fact, the project board TCs were taken up by recruitment and retention TCs when we started. So we said, no, we need a separate forum so that everybody doesn't have to be involved in that. So we also had a weekly recruitment and retention TC for that. The trial steering committee met once a year, and it was composed of international experts. So we had plenty of good advice from them. And as part of the EC funding, which I'm sure some of you who are in the European funding stream will know, you have to write 18 monthly reports, and of course the AKU Society, as part of that, had to contribute to that. Okay. They also had to produce not just a scientific report, they also had to do a finance report as well as audits as they went on. There's not much role for the AKU Society in analysis, but you can see how challenging it's going to be for us when we are reaching where we are now. So this is sort of summing up for you in terms of my bit. Out of the 138 patients that we recruited, 113 are still there. So I don't know how you would view that. I was a bit disappointed myself. In this last year, patients are pulled out for personal reasons. Okay, no good reason except that they're no longer, and most of them happen to be in the no treatment arm. So it's a little bit of a worry for us going forward. I think we've done the best we can, but it's still pretty challenging. So the clinical phase of the project started 1st of November 2012 as a 5.5-year project. So we're overrun. We've got a 9-month extension. We'll be finishing 31st of January 2019. Of course, we'll have to continue providing reports because of Brexit. They've asked us to finish early, but they still expect us to keep informing them about the final outcome of the study. So Brexit again, interesting. And of course, publications we will be doing, as would be the AKU Society, and of course, we're still very active in terms of webinars, letters that are informing patients about the outcomes, as well as through the AKU website. Now, this is Kiran's presentations. I hope I can do him justice. I won't have the same slant that he has, because I'm sure the patient society will have a different view of the clinical trial than I have, but I do have some of his thoughts. Again, he mentioned the small numbers and the challenge and the fact that there's no English and Scottish patients, mentioned the travel time and the time spent in hospital for busy people as well to come. The no treatment arm is particularly challenging. It was really difficult when you had patients there at randomization to tell someone you have got the drug or you haven't got it, and we had a list of retention things that we had to go through to emphasize why it was important for to stay in the study and support the study. Some of the patients also, is it ethical for you to have a no treatment? Of course, you need a comparator. You can't run a clinical study looking at the efficacy of a drug if you didn't have a comparator. So it's a difficult one. But many of the patients did come on knowing all that. Of course, pre-screening was a big challenge for this study. You've heard me tell you about the 138 patients we've already recruited. They wanted fewer visits. So I don't know if you think of a usual trial. If I think of a usual trial I would be doing with this kind of patients, totally in Liverpool. I would have been seeing the patients every 3 months or every 6 months. And of course, we have compromised on that because we just can't afford to pay the airfare and to get patients here for so long to come around to take part in the study. So therefore, less patients. So that means we had to do a lot of questionnaires, which the AK Society do every 6 monthly to see how they're getting on. In terms of retention, as I said, we were doing retention TCs once a week, and the AK Society in Cambridge was really important to ensure that patients stayed in the study. There were lots of blogs, there were webinars, there were email contacts, at least once a month with all patients. So 41 patients that we had in the study in Liverpool. They were pretty busy, and they are still pretty busy in supporting, even though it is a little disappointing for me to see an 82% retention rate compared to what we had even last year. In terms of dissemination, the AK Society's role in this trial is two things. One is patient support, patient issues, and the two is dissemination. So they are the disseminators for the study, and they're well organized now. And we have a consortium website. So there is an AK website, but there's also a DevelopAKUre website. Through all the mechanisms that are listed there, we're still informing patients, keeping them all informed about the things that we're doing. We're running also an international workshop. We had one in Liverpool just a few months ago, and it was highly successful. There are people from all over the world who came for that, from the US, from Europe, from India, from the Middle East. There were lots of places who came there. I'm just going to finish off with 2 slides in terms of messages. First one is, these are lessons that Kiran said we need to share with you. Patients and partners cannot be understated, which is correct. They know more than you think, he said. The logistics can be the hardest part. Problem issues should be fixed as soon as possible. Dissemination is king, he said, and patients treated as VIPs. So simple things have made a difference. The trial would have collapsed because we couldn't pay patients £50 for their expenses when they came to the clinical site. Because the hospital bureaucracy, NHS bureaucracy, there's no mechanism to pay them quickly. Of course, by transferring some budget from the hospital to the AK Society, we just got rid of it. And patients were then happy to stay. Okay, we're spending nearly £3,000, £4,000 on each patient for travel per visit, and this was the one that was going to cause us grief. So he's absolutely right in terms of what he said. So this is the last slide. So in terms of overall key points I want to make, I think they are a key group, AQ Society and other societies. I'm sure there are key groups to represent patients in clinical trial. They can contribute to very different aspects of this, not just patients. I think for us, the AK Society have taken part in almost all aspects of planning and delivery of SONIA 2. You need an effective patient society if you're going to do any clinical trial activity. And of course, regulators and funders are very keen these days to see a strong patient representation. I think we were very lucky with the AK Society. So I'll stop there. Thank you.